Okay, hello everyone. Welcome to Tuesday Morning Report. My name is Zakariyya G. Very excited to discuss today for the first time actually with Ravi and learn from him. I put it in the chat before we started, but I just took leave for 10 days and I feel like I've forgotten absolutely everything. So feeling super rusty, but thought this was a good way to restart my time.
Awesome. Yeah, welcome, Zakariyya. I'm very delighted to have you here, co-discuss. And before we get underway with the case, I just wanted to highlight Sime, who stepped in. We didn't have a case presenter, but I want to check in on Sime and appreciate her for presenting this case. How are you?
Hi, everyone. Thank you for kind words, Dr. Ravi, and very excited to present. And now that after seeing you all, I'm doing great. And after Saket says hi, maybe we can get started.
Awesome. And also wanted to introduce Samantha, who is helping us with scribing. How are you, Samantha? We just talked briefly about application season going underway.
Yeah, I'm doing really well. Just, enjoying my last few days of freedom before I have to start my next rotation. But it's great to be spending this time with all of you.
Awesome. And I hope to see your cat make a guest appearance at some point.
Fingers crossed. She does what she wants, but we'll see.
Awesome. The pets of CPS VMR. Yeah. And we have Sakith, who's helping us with teaching points. How are you today?
Hello everyone, I'm doing well. Really excited to see Mi's case today.
Awesome. Thank you for signing up to do teaching points. And let's get underway with the first aliquot. And Zakariyya, you'll have first stab at the first aliquot.
So we have a 30-year-old woman who presented with recurrent severe headaches. And as for the history of presenting illness, the patient says that she has headaches for the past 2 months, and they are intermittent and pounding, associated with dizziness and occasional palpitations. And she says that she also has episodes of sweating and palpitations with these headaches. And there is no photophobia or fever present, but nausea is present. And the episodes, they resolve on their own and last for about 20 to 40 minutes. And in the review of systems, there is no chest pain, shortness of breath, diarrhea, or weight loss. But patient complains of having heat intolerance. And I'll stop here and would love to hear your thoughts.
Oh, fascinating. Yeah, it's quite interesting that the last time I discussed was about 3 weeks ago, and we had a very similar syndrome with somebody having new onset headaches with worrisome red flags. And I think just to quickly go through those, the base rate of disease usually will suggest primary headache syndrome, most commonly migraines or tension headaches. But whenever somebody has a new onset of headaches, what we're really looking for is secondary sinister cause. And we go through the red flags in terms of the sudden onset, severity, and associated symptoms. And this patient seems to have some of them in the form of dizziness, palpitations, and nausea. But I think the thing for me that makes me wonder if this headache is potentially not necessarily the center of gravity is the fact that many of the associated symptoms I translate to sympathetic toxicity. And patients who have any sort of sympathetic toxicity from a toxidrome, anxiety, and so on can often have headaches associated with it. So I think for me, I'd be interested to know about the patient's past medical history and to see if there's any sort of focal neurological signs on physical examination. But I don't necessarily think that the patient, if there's no focal neurological deficits, might necessitate immediate imaging unless something suggests otherwise. And I'm curious to hear more from Ravi.
Absolutely wonderful start, Zakariyya. This reminds me, there was a case recently that you discussed where hyperadrenalism, Con syndrome, it's kind of started off in the same footing, and you just going into the world of sympathetic overdrive reminded me of your discussion. Wonderful discussion. I would implore people to check that episode out. And what's interesting, I think I'm onto the same kind of suspicion of there's a sort of conglomerate of different conditions happening here. The headache may not be like we usually go through a schema of headache, primary, secondary. So maybe might not be the primary driving feature of this case, but it's associated with something that's going on intrinsically in the patient. So we have dizziness, palpitations, sweating, nausea. So headache and all of these symptoms, I'm kind of worried of maybe nervous system disorder, endocrinological disorder. And there are features that are not alarming that you had mentioned. There's the fever. It doesn't exclude infection, but there's always less likely. If there was a fever with headache, I would worry about meningitis and encephalitis and so on. But here, no photophobia, that lessens the likelihood of this condition. But I think if we put all this pounding, palpitations and dizziness, it's a systemic condition. Where does the answer lie? I don't know. I can't say it's purely cardiac. I cannot say it's purely neurological, but there is something at play which affects all these different systems. So we're talking about a multi-system disorder here. And what kind of conditions can play on these systems? Maybe I think endocrinological kind of comes to mind here. And what links the brain and the cardiac system, the GI system, and so on is the nervous system. So I'd say nervous, neuroendocrine, endocrine, and I would look at more data to see if one of those I can pigeonhole into one of those systems at this point. So I'm not going to commit to diagnosis at this point, but I'd be interested to align my questioning along these systems to try and tease out more relevant facts to see which key actually fits the lock for this condition here. Any other thoughts, Zakariyya, before we turn the mic back to Sime?
Yeah, no, I absolutely love that. And I think if you just, one thing to add is if we're discussing episodes that start suddenly and stop, I start wondering potentially about like something like a migraine if you're talking neurological, but the other thing that comes to me is seizure. Right. And then if you're talking more systemically, I wonder about the substance. And yes, you're absolutely right. It could be endocrinological from something like a pheochromocytoma, but it can also be due to an external substance, where, for example, cocaine, or something like that. So yeah, I think a urine tox screen would be very helpful, and I'm eager to hear more.
Really interesting thoughts. I began with headache, and you guys were already thinking about systemic toxicity, which is amazing. So as for the past medical history, patient has history of hypertension that was diagnosed in 8th grade, and it was labeled as essential hypertension. And she was diagnosed with anxiety and depression 2 months ago. And as for the medication, she is on nifedipine, losartan, thiazide diuretic, atorvastatin, and the patient says that she has inconsistent adherence with her medications, and she feels worse after taking her anti-anxiety pills. And she is on duloxetine that was started 2 months ago for her depression and anxiety. And as for the family history, it was very interesting that patient said that many people in her family, they died before the age of 50, and she was not sure of what cause, but she said that because of some heart issues. And she has an uncle who had a neck mass, maybe thyroid something, and just passed away before 50 as well. And as for the social history, patient is not a smoker, but has heavy alcohol use history. And as for the recreational drug use, patient tried to avoid these questions and did not want to talk about it. And I'll stop here and would love to hear what you guys are thinking.
Very interesting background that you've laid here, Sime. I think now what we have to do, we sort of kicked it off, Zakariyya, with thoughts of systemic features, external features like substances. That was brilliant. I think, yes, in a young person, be non-judgmental, be objective, and you have to consider that substances, unfortunately, can play havoc on the body and present with something like this as well. And it could be substance or substance withdrawal as well. So there are certain behaviors, the heavy alcohol use definitely concerns me, and avoided substance use questions. So you definitely would have to do in the testing, get some data to make sure there's nothing that the patient is taking that could be contributing to this. The family history, early death prior to age 50, cardiac. So remember early on, we hypothesized that there's something there, and it's not uncommon to have sort of, I was getting this feeling of anxiety, some psychiatric features, although we don't want to play the role of being a medical gaslighter and just say, oh, your symptoms are due to just anxiety, just it's in your mind and so on. It's not something real. And unfortunately, sometimes going along that path or method of thinking can allow you to miss certain diagnosis, which can result in dramatic harm to the patient and adverse events. So we definitely want to do our due diligence and do consider cardiac issues here. There's family history, substance use disorder, before we just label it anxiety and depression. What's interesting, this anxiety and depression could be fueled by what we initially talked about. Could be endocrine, neuroendocrine, sympathetic, all of those certain things. They could be perpetuated by substances. So the convenient diagnosis of anxiety, depression, there could be a background. I would ask more if there was anything that triggered this, anything in the history that could have brought on anxiety and depression. And the last bit of the past medical history, the high blood pressure. You know, the headache, I was thinking initially when you mentioned headache, I was thinking about high blood pressure. We do have a large number of patients, and their thermometer for high blood pressure, sometimes what brings them to the hospital is the headache. Oh, I have a headache, and you put a cuff on and you see the blood pressure is 200 over 100, and that's what brings them into the hospital. So I'm not sure what the blood pressures, if they've been controlled on these medications. She's on a good regimen, so we always think about A plus C plus D, so ASAR, calcium channel blocker, diuretic, and she's on everything that should be first line. And in spite of this, if the blood pressure, when you present the exam, if the blood pressure is like out of control, in this case, 3, 4 more blood pressure medications is uncontrolled. First question is the patient taking it? Second, if it's not controlled on these medications, you have to start worrying about secondary causes of high blood pressure. So a lot of different features here I would worried about, but it definitely would trigger testing to see, especially with cardiac, blood pressure, and substance use Zakariyya had mentioned. But I'll turn the mic over to Zakariyya for any more ideas with this new bit of data.
Yeah, brilliant discussion. I actually got disconnected for a second, so I missed something. So I hope I'm not repeating what you said, but absolutely agree with you. And I think just the diagnosis of hypertension in 8th grade is an immediate red flag. You definitely can have primary essential hypertension in teenagers and people in the young 20s, but the younger you are, the more that becomes a diagnosis of exclusion. And I think this patient having ongoing hypertension despite being on multiple agents, definitely makes me think that there's going to be a secondary cause. And I think just to prove that the patient actually has had long-standing hypertension, if you have an ophthalmologist or the skills, you can do ocular screening. But I think for me, from the start in this sort of patient, I would be considering getting a urinalysis to look for any signs of renal dysfunction, and potentially an ECG, as well as an echocardiogram, to see if this hypertension is really true and has had consequences on the patient. Yeah.
Okay, back to you, Sime, for the physical exam and vital signs.
Love the discussion, and especially how you mentioned about not to dismiss the patient, just saying it is all anxiety and depression, because patient says that since 8th grade, she has sometimes been dismissed, labeled as having anxiety, and symptoms are not seriously thought of. But having such a family history of so many relatives dying, so we were very concerned for this patient. And to clarify, hypertension was still uncontrolled despite being on these medications. However, patient said that she did not have a very good adherence to the medication. And the patient at this visit was afebrile, and heart rate was 112. BP was 160 over 90. And in the general examination, patient was anxious and had fine tremors in the hands. And in the cardiac exam, patient was tachycardic, but we could not find any murmurs. There was no jugular venous distension, and lungs were clear, and abdomen was soft. There was no bruit or organomegaly, no tenderness. And in the neurological exam, patient was alert, no focal deficits, and reflexes were normal, and musculoskeletal exam was also normal. And I'll add EKG and echo in this aliquot as well, so we can have a good discussion. So EKG showed sinus tachycardia with occasional premature ventricular contractions, and echo showed mild concentric left ventricular hypertrophy, but ejection fraction at this point was preserved. And would love to hear your thoughts.
Yeah, amazing. And I think just to start off with, this patient meets a constellation of syndromes that, especially with having a history of alcohol use, should make you first worry about the most morbid diagnosis in the moment, and not necessarily that her vitals and her physical exam is just related to whatever the cause of her presumed secondary hypertension is. And that is alcohol withdrawal. She is tachycardic, hypertensive, has a tremor, and has a history of alcohol use. And not treating that appropriately, if that is part of her current presentation, can actually have a devastating outcome. So that's just something I don't want to miss. But if we presume that these vitals are related to the cause of a secondary hypertension, the fact that she's tachycardic despite being hypertensive, as tachycardia is either to protect you from hypotension or due to some sort of sympathetic toxicity. And I think just like the last case a few weeks ago, I really wonder about the possibility of a pheochromocytoma or paraganglioma, especially, and then if you start to talk about other family members also having secondary hypertension, I'd worry about potentially something genetic, which can include the men's syndromes that, in addition to being associated with a pheochromocytoma, can be associated with other pituitary abnormalities, which might explain one family member having had a neck mass previously. So I think for me here, this is a place where I really want a TSH, and I might actually start getting those the catecholamine labs early, and then not presuming that will lead to the final diagnosis, but potentially then adding on a detox screen to see, because we don't really know, as she hasn't yet disclosed if she does take any other substances. Yeah, so I think that's where I'm at, and I'm eager to learn more from Ravi.
Oh, Zakariyya, absolutely wonderful. Now you're reminding me of that discussion that you had with Charmaine with this adrenal overdrive in this patient, Con syndrome that she had. So absolutely wonderful. You know, it's interesting. I just rounded this morning on a patient with a paraganglioma, and exactly what you mentioned were the teaching points that I brought up with my medical students and residents. So definitely these things are to be considered. And I'm all very interested with the substance use disorder hypothesis as well, especially alcohol withdrawal could easily explain a lot of this. You know, the blood pressure goes up and so on, patients having tremors. You definitely have to wonder about this. But what do they always mention about such conditions, such as DKA, such as alcohol withdrawal, is you kind of want to take a peek behind the curtain and see if there's something else, because these syndromes are so aggressive in themselves, they can mask a lot of underlying disorders. So you do want to do your due diligence and then look, because say you have a patient that's been drinking heavily for a while and suddenly they stop and go in a withdrawal. Maybe it's something that's festering behind the scenes, maybe an intra-abdominal catastrophe, and they just couldn't drink anymore. And now they're presenting with withdrawal, but now within their abdomen, they could be developing an acute process. So you got to be really careful with such patients. So certain things that can be masked by alcohol withdrawal, could be sepsis, could be any sort of anatomical abnormality, cardiac abnormality, or anything like that. I'm going to kind of roll back to this duloxetine. This duloxetine, what Seema was you were mentioning, makes the patient feel worse. So I was like, okay, what exactly is the role of duloxetine here? And it should be helping her, right? It's a serotonin reuptake inhibitor. It should be helping with her anxiety, but she's feeling worse. So either some of these other syndromes are happening on top of it, so it's not really helping her, or maybe it's adding fuel to the fire. So it can, in some certain circumstances, you can develop emergencies, neurologic emergencies like serotonin syndrome, but I don't see any other medications that it could be increasing the likelihood of serotonin syndrome with. But you can get agitation, you can get this jitteriness, you can get insomnia and so on happening with this initially before it starts to take effect. I think it can take like maybe a couple of weeks before it starts working. So I'm wondering if duloxetine has a role to play with this. And maybe she's in the throes of the first few weeks of having duloxetine associated sympathetic overdrive as well. But they always say, right, when you do psych, when you do give an SSRI like this to monitor for suicide attempt, it can happen initially when you place a patient on a medication like this. So that's one of the things that comes to mind regarding this med. But I don't see likelihood of serotonin syndrome in this patient, but it does develop like this, and it can happen in the first week or two, or this just could be the patient developing the initial sympathetic hyperactivity due to this medication before it starts to take effect. But everything else you said, yeah, I definitely would look at Zakariyya. Oh, is he still here? Oh, there you are. Okay, I thought I lost you. Yeah, so Zakariyya, all the other endocrinological testing I would worry about. In addition, I wonder with this patient, we should also start to treat for alcohol withdrawal. Has a patient gone through DTs or alcohol withdrawal in the past, Seema?
No, and she said that recently she was not drinking too much, and she last had a drink at a party 3 days ago, but she did not drink a lot. She's trying to cut down on alcohol recently.
Got it. It's also interesting, I've observed, you also have to ask exactly what the patient's drinking. If they're just drinking beer, I've had patients come in, the alcohol content is not that much and they don't go into withdrawal. But if they're drinking fine spirits, they tend to have higher alcohol content. They will develop within days, 48 hours, 24 hours withdrawal, and then go through all the different withdrawal, acute alcohol withdrawal, delirium tremens, and so on. Any other ideas before we turn the mic back to Seema, Zakariyya?
No, not at all. I'm learning so much. Incredible discussion, and yeah, I think I'd just love to hear more.
Okay, take it away, Seema.
So now we have some labs. So patients' WBCs were 14,000 with neutrophilic predominance. ESR and C-reactive protein, they were a little elevated, and electrolytes were normal. We just had potassium of 3.3, which was a little low, and glucose was 210, which was elevated, but HbA1c was normal, and creatinine was 2.5. And we also checked for thyroid levels, TSH, and free T4 were normal at this point, and urine drug screen is also negative. So these are the labs for now. Let me know if you want further tests or what labs you want further, and would love to hear your thoughts.
Zakariyya, what do you think? I don't know if it was you or me that was possible.
As well.
Okay.
Yeah, so I think none of these labs really surprised me. I translate the patient having tachycardia with an elevated glucose and slightly lowish potassium to simply mean that the patient most likely has a sympathetic toxicity from whatever cause. But as in the last case, we had an extensive discussion about primary hyperaldosteronism and refractory hypertension with hypokalemia, especially when associated with underlying renal dysfunction, should make you worry about that cause. And there are absolutely genetic forms such as familial aldosteronism that can do this. But I think for me, in addition to sending off those labs with the renin and aldosterone level, bearing in mind that the patient is on an angiotensin receptor blocker, which can slightly interfere with the results, I'd want to be sending off the labs for catecholamines, including urine studies. Yeah, so I think that's where I'm at, and I'm not sure if you have anything else to add.
Yeah, absolutely. The lab parameters, looking at the chemistry, yeah, hypokalemia. I don't know what the bicarb, but usually metabolic alkalosis. Creatinine is up. This does suggest likely hyperaldosteronism. But yeah, we would proceed with doing aldosterone and renin testing. The white count is interesting here. I can't just ignore 14,000 with neutrophilic predominance. So what could cause such a high, at least the white count is an 11, which we can kind of dismiss because of stress, anxiety, and so on. So with the mechanism of hyperaldosteronism and increased sympathetic overdrive, you could get demargination of white cells to this level. But before you consider that hypothesis, you have to do your due diligence and take a look at the patient and make sure there's no infection that's also simultaneously happening as well. Occasionally, we rush to judgment and we find a convenient diagnosis. It could be a patient coming in with hypotension due to overuse of the diuretic, and we consider that the cause of the hypertension, but there's a white count. There is neutrophil predominance. There could be bandemia. There could be sepsis brewing in the background as well. So you have to at least entertain when your white counts up, if there's neutrophil predominance, differential is pointing towards, it's usually not, this isn't called a left shift. Neutrophil predominance is high neutrophils, but left shift would be bandemia. You look for other supporting cast members of SIRS criteria. So SIRS is very good in trying to identify sepsis. And then QSOFA, the severity of sepsis, which is very good. I usually remember QSOFA as a hat. So hypertension, altered mental status, and tachypnea. So here, I don't have a respiratory rate. The blood pressure actually is higher than low. So we're probably not in this septic stage, but could we be in SIRS? Definitely, I would get a lactate. The white count's high. I would look over the patient. Remember, like I said, with alcohol withdrawal, you have to look for coexisting infection, certain conditions like DK. You also have to do your due diligence and look for infection. But here, I definitely would look for an infection. And if I do a head to toe and I don't see what are usually the most common causes of infection in hospitalized patients, looking at GI, GU, respiratory, CNS disorders, also look at the largest organ in the body, look at the skin. And if there's no sign of an infection, the temperature is afebrile. So like a predisposed probability for infection is lower, I can attribute it to pain, stress, sympathetic overdrive, causing a large demargination of white cells. Usually this is a quick up and down. Tomorrow you repeat the CBC, the white count will decrease. Dehydration, white count's up, it will decrease. Hemoglobin, same thing, hemoglobin's concentrated, give fluids, it comes down. So at this point, I'm not getting the flavor of infection, but I have to force my mind to go through this and not miss. I know of ample cases where this has happened. We have a very convenient diagnosis. We anchor to this, and we then miss a simultaneous infection or maybe some other condition that's happening or pre-existing at the same time. So that's kind of at this point, I am not inclined to think of an infection, but then I will revert back to what we were talking about. So hyperaldosteronism is very much front and center of this case, I think, right now. So that testing will help. If testing is negative, we can move on and look at other causes that we had entertained earlier. Anything else, Zakariyya, before we turn the mic back to Seema?
Yeah, I think I just want to reiterate that I don't think I've really thought so much about any cause of SIRS. We usually just think about infection, but anything can do it that makes a patient acutely ill. And I've seen a patient who had recurrent DKA, specifically not due to any trigger besides just improper use of the medication and poor patient education. And that patient would come in with DKA and white cell counts in the 30s, that would just get better as you treated the DKA. But those are always the diagnoses of exclusion, and you always have to first think about infection. And I think just the other thing to add is ischemia. Acute ischemia you are often more morbid than even an infection, and can definitely cause an neutrophilic leukocytosis.
Excellent, Zakariyya. Yeah, back to you, Seema.
Loved the discussion, and lactate at this point was normal, and we got aldosterone to renin ratio, it was also normal, and cortisol and ACTH are normal. And CT scan was done at this point of abdomen, which showed 3.9 into 3.3 centimeter heterogeneous left adrenal nodule with a central hypodensity. And I have some more labs, but I'll reveal that in the next aliquot and would love to hear your thoughts.
All right, I'll start off this time, but yeah, now the imaging has revealed a lesion of interest. So the kidney, Zakariyya initially described in detail, like the kidney failure, the lab pattern, recognizing the pattern, and then putting alongside that the whole host of different signs and symptoms. So definitely, I think further endocrinological testing, aldosterone, renin levels will be necessary here. And anything else, Zakariyya, before we turn the mic back to Seema for more data?
Yeah, I feel like in some ways it's such great space repetition of the last case. I'll try to find that case and put it in the chat. But yeah, I think to me, this patient has a pheochromocytoma until proven otherwise. And with the family history, I'd be wanting to look for any of the other associated patterns of Meniere's syndrome as well, including possibly genetic testing. Yeah, and I think just to be very careful when a patient, you think a patient has a pheochromocytoma, because when you think about consequences of it, in terms of that they can be malignant, you can find them elsewhere in the kidney besides the adrenal glands, but just managing this patient in terms of the medications you give can also be catastrophic. And I think I remember something. I don't fully understand. I don't fully remember the logic behind it, but the fact that when you treat this patient, you have to actually give them alpha blockers, as otherwise you can cause a severe sympathetic toxicity. But it's a little bit of a knowledge gap, and I'm sure Ravi can iron out the kinks in that.
Yeah, exactly. Yeah, I think, yeah, if you find that case, it's going to be great to augment the learning with this case today. And what I remember, if you've had a patient with pheochromocytoma, it's just marked the way they present. So they're not constantly in this sympathetic overdrive. They'll be fine, absolutely fine, sitting in bed, no issues, and then suddenly the sympathetic surge will just activate and they'll be diaphoretic, their blood pressure just skyrockets, they start having tremors, and then after a certain while, and you have them on meds, then they revert back to normal. So this intermittent, remember at the beginning, Zachary, you mentioned, or Seema, you had mentioned this intermittent episodes. It very much fits the patients that I've had before with pheochromocytoma. So thankfully, it's not a common condition, but very important, like this patient trying to at least diagnose it and entertain the diagnosis to determine what is going on. Because like with the blood pressure, you conveniently make a diagnosis, the blood pressure is high, you put them on medication, send them home, but you do want to do your workup for secondary causes of high blood pressure along with all these signs and symptoms. And it does fit this scenario of intermittent exacerbations of flare-ups and then suddenly periods of normalcy. So it'll be interesting to at least get more information to see if it fits the picture. Back to you, Seema.
Wonderful discussion. And now I have the last aliquot. And renin aldosterone levels, they were normal. And we got plasma-free metanephrines, which were elevated, and 24-hour urine fractionated metanephrines, they were also elevated. And because of the strong family history, genetic testing was done in this patient, and a RET proto-oncogene mutation was identified, and calcitonin, PTH, and calcium levels, they were normal. And I would love to hear your thoughts and reflections.
Yeah, just an incredible case, and I think we're quite confident in the diagnosis of pheochromocytoma secondary to a genetic abnormality. But I think I'm just reflecting on how this disease that's extremely rare, if you go through how you work up getting to the diagnosis, it just illustrates and allows you to learn so much about things that you see much more commonly. So I would just say to anyone watching, not necessarily to take out from this case how to diagnose a pheochromocytoma, but to think about alcohol withdrawal, to think about secondary causes of hypertension, yeah, it's just a great case. I think that with so much bread and butter learning beyond just the esoteric. I really appreciate it, Simi.
Yeah, I absolutely agree. You're onto something there, Zakariyya. And I think the chat was also mentioning Dadmir is mentioning, Vinny also mentioned. So remember, we talked about, let's go back, look at this duloxetine. So if you think about it, this patient has pheochromocytoma, but then the duloxetine is suddenly adding fuel to the fire. It blocks norepinephrine, serotonin reuptake. So you give this to a patient with pheochromocytoma, they're going to be coming in to be evaluated a lot sooner because you are making the situation worse. So maybe adding this medicine made her worse, and she presented, and they were able to then make the diagnosis of pheochromocytoma in this patient. Any reflections, Sime, on this case? Wonderful case, by the way.
Thank you, and just amazing that how I began with headache, and you were already talking about toxicity and sympathetic overdrive. So love the discussion, and just want to add that because right gene was found, so it was thought to be associated with MAN2. And yeah, it's a very rare case, and love the discussion and how she walked us through all the possible causes we can think of. And thank you so much.
Thank you. Wonderful. I appreciate you bring this case at a short notice. And we'll turn it off to Sakith for teaching points.
Hello. Wonderful case, Simi. Thank you so much. Definitely learned a lot. So we started off by talking about headache, and the first tool is to always look for red flags. Our job is to make sure it's not a secondary headache, and whenever a headache is accompanied by, in our case, palpitations and diaphoresis, for example, it points us towards a systemic syndrome. And here we think more broadly about external causes like toxins or drugs, which could be causing the headache, or internal causes like hormones, classically a pheochromocytoma in this case. Next, we considered the young patient with high blood pressure. In this group, the secondary causes of hypertension become extremely important, and even something like poor medication adherence can manifest as a secondary headache. Then we layered in the hypertension plus tachycardia. Now, the combination of these both makes us think about sympathetic overdose, and the causes can range from alcohol withdrawal with tremors to endocrine etiologies like pheochromocytoma, hyperaldosteronism, or hyperthyroidism, to genetic syndromes as well. Again, important to make sure it's not a drug overdose. And importantly, as Dr. Ravi mentioned, withdrawal can sometimes mask acute pathologies like sepsis. So may just need to keep an eye out for that as well. Coming to the labs, that gave us our first clues. Hypertension plus hypokalemia should always raise suspicion for hyperaldosteronism, but also sympathetic overdrive itself can cause hypokalemia. And the leukocytosis that we saw in this patient, it can be secondary to the pain and sympathetic stimulation causing demargination. But again, like we mentioned earlier, it's always important to rule out an infection as well. Finally, the imaging along with the clinical picture with intermittent symptoms of pounding headaches and diaphoresis gave us features that are very particularly suggestive of pheochromocytoma. And in younger patients, we should also consider the possibility of genetic syndromes associated with secondary hypertension. And that's what this patient ended up getting diagnosed with, the pheochromocytoma, likely secondary to a MAN2 syndrome. Thank you so much, everyone. This was a really incredible case.
Thank you, Sakith. Wonderful teaching points. You were able to grab everything in such a succinct manner. And also thank you, Samantha, for doing scribing. Sime, again, wonderful case. I don't get to think about pheochromocytoma often. And also Zakariyya, wonderful. Again, I loved that you were mentioning the sympathetic system and the physiology. So I got to relearn that from you from your previous case. And you did put that case in the chat there. So we'll be re-exploring that hopefully soon. Thank you, everybody, for attending, and have a great rest of your Tuesday. Bye.